Welcome to the Radiographics Podcast, brought to you by RSNA. I'm Wendy Gibbs. This week on the podcast, Ross Frederick will be summarizing a paper about a very important topic, invasive fungal sinusitis. These infections can progress so quickly. I've seen patients progress from diagnosis to death in 3 days. So it is important that we can recognize the features if the patient is to have any hope of recovery.
Deadly fungi, invasive fungal rhinosinusitis in the head and neck. Invasive fungal rhinosinusitis is a life-threatening condition that mainly affects immunocompromised patients. Many species of fungi can cause an acute invasive infection. Mucor, Rhizopus, and Aspergillus species are common causes. Invasive fungal sinusitis has an unfavorable outcome mortality rate of 20 to 80%. Pathogenic fungi spread by means of direct invasion through osseous structures and the skull-base foramina and along the vessels and nerves. This can result in devastating intracranial and extracranial complications such as optic nerve ischemia, skull-base osteomyelitis, mycotic aneurysm, inflammation and invasion of the internal carotid artery, cerebritis, and brain abscess. Early diagnosis and prompt treatment, including antifungal therapy and surgical debridement, prevent rapid deterioration and fatal outcomes. The most commonly reported risk factors include poorly controlled diabetes, hematologic malignancies, organ transplant, immunosuppressive agents, and immunosuppressive diseases such as HIV. Patients with these factors are susceptible to mucor species because the phagocytes become dysfunctional with impaired chemotaxis and deficient intracellular killing. In addition to impairing the patient's defenses, mucor species can adhere to the endothelial cells by expressing specific proteins and can cause endothelial damage. The COVID-19 pandemic has increased the importance of fungal infections in public health because patients with COVID-19 are at higher risk of contracting invasive fungal sinusitis. Learning about fungal sinus disease can be confusing initially because there are several different types. There is the more dangerous invasive form, which we are covering in this article. There is also the non-invasive form, which includes mycotomas and allergic types. Mucormycosis and aspergillosis destroy tissues through hyphal invasion via the blood vessels, causing vessel thrombosis, tissue necrosis, and dissemination to other organs. The symptoms of mucormycosis and aspergillosis can overlap. However, further deterioration after treatment with antifungal agents against aspergillosis and the existence of uncontrolled diabetes are suggestive of mucormycosis. The mortality rate of mucormycosis is higher than that of aspergillosis. The most common presenting symptoms of invasive fungal sinusitis include facial swelling, fever, and nasal congestion. The most common anatomic locations for invasive fungal sinusitis are the nasal cavities, typically the middle turbinates, followed by the maxillary sinuses, ethmoid sinuses, and then sphenoid sinuses. A diagnosis of invasive fungal sinusitis is made on the basis of histopathologic examination of endoscopically removed tissues. Imaging findings of invasive fungal sinusitis are not easily distinguishable from those of bacterial infection. One study reported that the involvement of any two of the 7 anatomic structures, including periantral fat, bone dehiscence, orbital invasion, septal ulceration, the pterygopalatine fossa, the nasolacrimal duct, and the lacrimal sac, was predictive of invasive fungal sinusitis with 100% specificity. When sinus involvement is present, MRI is an appropriate tool for detection of extrasinus involvement due to its superior tissue contrast compared with CT, and is more effective for intraorbital and intracranial evaluation. At CT or MRI, loss of contrast enhancement at the sinus mucosa indicates fungal vascular invasion, as exemplified by the black turbinate sign on post-contrast images, which is more commonly seen in patients with mucormycosis. However, it is important to recognize that imaging findings may be mild, particularly in the early phases of the disease. The degree of sinonasal mucosal thickening may be mild and is not sensitive or specific for the diagnosis of the disease. The characteristic imaging findings of extrasinonasal soft tissue invasion include infiltration of the surrounding structures, including periantral fat and pterygopalatine fossa, bone erosion of the paranasal cavity, and contrast enhancement of the surrounding soft tissues. Mild periantral fat stranding is often the first sign of vascular invasion and spread beyond the paranasal sinuses, so make sure to inspect these areas carefully. Normal soft tissue surrounding the paranasal sinus demonstrates fat attenuation at CT and fat signal intensity at MRI. Therefore, fat stranding at CT and a loss of fat signal intensity on MRI indicate soft tissue invasion. Right to left comparison is helpful in detecting tiny abnormal findings in soft tissues. Irregular bone erosion and/or thickness of the paranasal cavity may indicate soft tissue invasion, although invasive fungal sinusitis can extend to the paranasal region without bone destruction through fungal perivascular or perineural invasion. So what are the main routes of extension for deadly invasive fungal sinusitis? There are 4: intraorbital extension, cavernous sinus extension, direct intracranial extension, and intracranial dissemination. Let's start with intraorbital infection, which may cause various forms of inflammation, such as orbital cellulitis or abscess, myositis, optic perineuritis, optic neuritis, and anterior or posterior ischemic optic neuropathy. Posterior ischemic optic neuropathy can be caused by the extension of invasive fungal sinusitis into the posterior orbital structures. The posterior part of the optic nerve is supplied by the pial plexus, which is derived from the ophthalmic artery and is susceptible to ischemia because of its poor vascularity. Clinically, patients with posterior ischemic optic neuropathy experience sudden vision loss and varying degrees with or without preceding amaurosis fugax. The surrounding structures are important routes of intraorbital extension and should be thoroughly evaluated. Direct invasion, angioinvasion, perineural spread, and osteomyelitis occur frequently as the infection extends into the orbit. Initial imaging findings include an ill-defined mass, orbital fat stranding, displacement, abnormal thickening, and enhancement of the involved structures. An inflammatory mass with adjacent sinusitis or inflammation of the nasolacrimal duct is indicative of intraorbital extension of invasive fungal sinusitis. The lateral displacement of the medial orbital structures is a finding that is suggestive of extension from the ethmoid sinus. Proptosis can occur because of retrobulbar inflammation and orbital apex inflammation caused by extension of the infection from the sphenoid sinus. Enlarged infectious masses and enhanced extraocular muscles indicate myositis. Posterior ischemic optic neuropathy shows loss of contrast enhancement and diffusion restriction, mainly in the posterior segment of the optic nerve. Diffusion restriction of the optic nerve can also have other causes, including demyelination and optic neuritis. However, loss of contrast enhancement is highly suggestive of optic nerve ischemia. Sphenoid sinusitis and inflammatory findings in the orbital apex are suggestive of extension of the invasive fungal sinusitis. Let's discuss cavernous sinus invasion, which can be devastating because it contains multiple essential neurovascular structures. Extension into the cavernous sinus may result in cavernous sinus thrombosis and narrowing of the internal carotid artery lumen. There are direct and indirect findings of cavernous sinus extension, and imaging in the coronal plane provides further information. Direct findings include destruction of the bony floor at CT, hypointense lesions in the cavernous sinus on T1 and T2 weighted images, and enlargement and expansion of the cavernous sinus with bulging lateral walls on coronal images. Loss of flow voids with restricted diffusion suggests cavernous sinus thrombosis. Indirect findings include narrowing of the ICA flow void in the cavernous sinus and dilatation and/or subsequent thrombosis of the superior and inferior ophthalmic veins. Cavernous sinus extension is usually accompanied by sphenoid sinusitis and/or an orbital apex lesion, and it can mimic a sellar mass. Isolated sphenoid sinusitis is a potential source of cavernous sinus extension, and patients should be evaluated for it routinely because it is easily overlooked. The differential diagnosis of cavernous sinus extension includes non-infectious inflammation and pituitary adenomas. Non-infectious inflammation can occur because of granulomatosis with polyangiitis or Tolosa-Hunt syndrome, which is granulomatous inflammation of the cavernous sinus region characterized by recurrent, painful ophthalmoplegia. Adjacent sphenoid sinusitis and the presence of risk factors are suggestive of invasive fungal sinusitis. Arterial involvement of invasive fungal sinusitis can occur because the fungal spores adhere to endothelial cells, resulting in perivascular spread, direct invasion of the arteries, vasculitis, mycotic aneurysm, and associated infarction due to arterial thrombosis or septic infarction. Mycotic aneurysms can occur because the fungi destroy and grow through the elastic lamina of the arterial wall while producing elastase, resulting in a decreased resistance to intra-arterial pressures and subsequent aneurysm formation. Fungal aneurysms tend to be fusiform with a longer shape and a more proximal localization of the intracranial arteries when compared with bacterial aneurysms. The tendency of the fungi to invade the proximal arteries leads to a larger infarction. Contrast-enhanced MRI or MR angiography and CT angiography are recommended for patients with fungal infections adjacent to the ICA, including those with cavernous sinus invasion, to evaluate ICA involvement and luminal abnormality. Thickening and enhancement of the ICA wall, with or without narrowing, indicates ICA involvement. In addition to MR angiography, high spatial resolution MRI of the vessel wall can be used to depict vascular involvement, which manifests as smooth or nodular wall enhancement. Let's discuss intracranial extension. Fungi can also spread intracranially through direct extension or through dissemination. Intracranial extension causes cerebritis, infarction, parenchymal hemorrhage, meningitis, brain abscess, subdural empyema, epidural abscess, thrombosis of dural sinuses, and arterial involvement. Furthermore, invasive mucormycosis has a tendency for perineural invasion, which can cause cranial nerve palsies, most commonly along the trigeminal nerve, followed by the olfactory nerve. Radiologically, contrast-enhanced MRI and FLAIR provide a better depiction of meningitis than that at T1 and T2 weighted MRI. Cerebritis appears as high signal intensity on T2 weighted or FLAIR MRI, with subtle mass effect and diffusion restriction, and may be the early manifestation of brain infection and brain abscess. Aspergillus manifests differently in immunocompromised and immunocompetent patients, whereas mucormycosis predominantly occurs in immunocompromised patients. Fungal brain abscesses usually show central diffusion restriction with solid or ring enhancement in immunocompetent patients and absent or ring enhancement in immunocompromised patients. Thickening and enhancement of the dura followed by cerebritis are the most frequent intracranial findings. Recognizing the imaging findings of perineural spread is also important in the diagnosis of intracranial extension. Perineural spread appears as thick enhancing tissue along the involved cranial nerve, with a loss of the normal fat pad of the foramen where the nerves pass through. Involvement of the ipsilateral pterygopalatine fossa in sinusitis without bone destruction indicates perineural or perivascular spread along the sphenopalatine artery. Involvement of the periantral fat is also a key finding in patients with perineural or perivascular spread. Invasive fungal sinusitis can also directly spread into the intracranial structures through hematologic dissemination. When the brain is involved in fungal dissemination, the gray-white junction, thalami, corpus callosum, basal ganglia, and perforating small artery territories are commonly affected because of the size of the sporangiospores of the organisms. So how is invasive fungal sinusitis managed? Early diagnosis and prompt initiation of therapy are essential for the management. Surgical debridement and antifungal drugs are the basic treatment options for invasive fungal sinusitis. Surgical debridement comprises excision of the necrotic tissues, improvement of drainage, and prevention of recurrence. However, repeated surgical debridement is often required. Let's recap a few key points. The most common anatomic locations for invasive fungal sinusitis are the nasal cavities, typically the middle turbinates, followed by the maxillary sinuses, ethmoid sinuses, and sphenoid sinuses. Intraorbital extension of invasive fungal sinusitis should be suspected in patients who present with symptoms such as blurred vision, diplopia, trigeminal hypoesthesia or hyperalgesia, proptosis, and chemosis. At CT or MRI, loss of contrast enhancement indicates fungal invasion in the vessels supplying the tissues, as exemplified by the black turbinate sign, which is usually seen in patients with mucormycosis. Normal soft tissues surrounding the paranasal sinuses demonstrate fat attenuation at CT and fat signal intensity at MRI. Therefore, fat straining on CT and a loss of fat signal intensity at MRI indicate soft tissue invasion. Isolated sphenoid sinusitis is a potential source of cavernous sinus extension, and patients should be evaluated for it routinely because it is easily overlooked.
That's it for this week's podcast. Take a look at the paper online or in the print journal, the last print journal, sadly, to burn these images into your mind. We look forward to seeing everyone at RSNA coming up so soon. Stop by the Discovery Theater on Monday morning and the Radiographics booth to see us on Monday afternoon.